So thank you everybody for joining this evening for our MS Academy webinar. So we're going to have 45 minutes covering vaccinations in people with multiple sclerosis in the era of highly effective DMTs. So this is a highly relevant topic to all of us. And for those of you that don't know me, I'm Claire McCarthy. I'm a consultant neurologist at Addenbrooke's Hospital in Cambridge, and I'm the MS clinical lead. So just to mention, there is a health and wellness on demand course that's available through the Neurology Academy, and this is focused on healthcare professionals, so not for your patients, it's for you, and it's a highly recommended course that helps prevent burnout, so worth having a look at on the website and sharing with colleagues. And I'd just like to thank our sponsor. So the webinar is sponsored by Novartis Pharmaceuticals, but they've had no input at all into the content of the session. So it's a great pleasure to introduce Aoife Shields, who is an MS pharmacist at the National Hospital for Neurology and Neurosurgery at Queen Square in London, and also Mari Coots, who's a MS specialist nurse working for NHS Ayrshire and Arran. And those are our disclosures. And then to run through the objectives of today's session. So we're going to start off by reviewing the latest guidelines on vaccination in MS from ECTRIMS and the EN that were published very recently in 2023. And we're going to compare that with the UK guidance. We're going to discuss what vaccinations are required when people start high efficacy treatments, and look at how we can approach vaccine hesitancy, which is a common problem, and then cover the immunosuppressed traveller, which is also a common scenario in our clinics. Great, so we're going to start off with Aoife, who's going to run us through the guidelines on vaccination in MS that were published by ECTRIMS and the EAN. So handing over to you, Aoife.
Thank you, Claire. So we know that the MS disease-modifying drugs have a mechanism of action that includes alteration of lymphocyte trafficking, lymphocyte depletion, and disruption of lymphocyte replication. Therefore, patients receiving them are at increased risk of contracting infection and potentially experiencing a more severe course of infection. This document is intended to guide decisions on immune vaccine strategy, this ECTRIMS EAN document. It was developed under the auspices of ECTRIMS and EAN, and so therefore will vary with UK practice. And that is because UK NHS immunisation practice must adhere to this green book. So its proper title is Immunisation Against Infectious Disease. It is written for health professionals by the UK Health Security Agency and is advised by the Joint Committee on Vaccination and Immunisation. So the ECTRIMS EAN consensus document is written in the form of questions, statements and recommendations. It covers a wide range of considerations, including vaccine strategy, efficacy and safety, and it covers specific subpopulations where guidance may differ, so children, pregnancy and international travel. It is both evidence-based and it brings together a consensus of expert opinion. There's a significant amount of evidence in the document, which I won't detail today, but I'll try and summarise the recommendations. So the first question to be addressed is vaccine safety, both within and outside the context of MS disease-modifying treatments. Thankfully, there's sufficient evidence to show that the commonly administered vaccines, for example, flu, tetanus, BCG, do not increase the risk of MS exacerbation or disability progression. The benefit of vaccination outweighs any risk. Inactivated vaccines can be safely used whether on disease-modifying treatment or not. And live vaccines are not recommended for patients on disease-modifying treatments other than glatiramer acetate or interferon. Second question is around vaccine effectiveness before treatment and after starting treatment. Studies show that response to vaccines is similar to the general population in treatment-naive people with MS or in those receiving interferon and glatiramer. In those receiving dimethyl fumarate, teriflunomide, natalizumab, antibody production can be lower in comparison, but they will still achieve sufficient seroprotection. In patients on S1P inhibitors and anti-CD20 antibodies, antibody production is lower than those who have no or lower efficacy treatments. And with cladribine and alemtuzumab, there is limited data, and this consensus group state that due to the drug's mechanism of action, a reduced seroprotection is expected with complete immune or until complete immune reconstitution is achieved. And actually, in preparation for the presentation this evening, we had a discussion with Clara about her research at Cambridge Pathology, which is referenced in this document. And many of the patients she studied post-Lemtrada had not had complete immune reconstitution, but had good vaccine responses. However, one patient vaccinated within 2 months of alemtuzumab treatment had a poor response to several vaccines, suggesting that immunisation very early after alemtuzumab may not be effective. So this is an area that's not straightforward, and hopefully more data will become available. But really the recommendation here is to counsel patients about diminished protection against infection and how to follow other protective strategies against infection. So question 3 asks what the recommended vaccine strategy before, during and after immune suppressive treatment should be. And it's perhaps the most wide-ranging question and challenging task. And the recommendation from this group builds upon previous AAN and European consensus groups, as well as vaccine use in other immune suppressed populations, for example, HIV. And really, when considering vaccine strategy, preparedness pays. So this section highlights the importance of being proactive with considering immune status and early vaccination at the time of diagnosis. So the first recommendation is an evaluation of the immune status. It's recommended for all MS patients. And recommendation 2, care providers should inform patients about the importance of immunisation and the risks of not vaccinating, and patient opinions, values, preferences should be considered. Recommendation 3, vaccination should be performed at the time of diagnosis or early stages of disease to prevent future delays in initiation of therapies. Recommendation 4, in order to define vaccine plan, it's essential to document the patient's past, current and future therapies and establish vaccine needs based on natural immunity and vaccine history. Rec 5, the vaccination guidance according to prescribing instructions for each disease-modifying drugs should be followed. Rec 6, in patients who are experiencing a relapse, vaccination should be delayed, ideally until clinical resolution or stabilisation. Recommendation 7, physicians should reassess vaccine status of patients before starting any immune suppressive therapy. And recommendation 8, for any people starting immunosuppressive therapy, inactivated vaccines can be administered at any time, ideally 2 weeks before treatment, and live vaccines should be administered at least 4 weeks before treatment onset. Recommendation 9, also that accelerated vaccine schedules can be proposed when available and if needed. There's also this really helpful slide actually that recommends interval between drug administration and live vaccine. It's pretty consistent with the manufacturer's prescribing information. This recommendation reinforces that live vaccines should be avoided in immune suppressive therapy due to the risk of developing vaccine-related infections. Rec 11 in this section gives advice on how to manage non-immune patients who are already on immune suppressive therapy if they get exposed to, for example, chickenpox or measles. And really that's to educate them to seek advice immediately as soon as they suspect they've been exposed so that they can be offered immune globulin if needed. Rec 12 suggests timing of vaccine around disease-modifying treatment. So, for example, 6-monthly anti-CD20 treatment and potentially postponing vaccines until immune reconstitution. Some people may disagree with this strategy. Let's take, for example, the flu vaccine. We may not want to delay a flu vaccine in the middle of flu season to fit this advice, particularly if flu season is over by the time or by the ideal time to vaccinate arrives. And similarly, recommendation 13 suggests measurement of vaccine-induced antibody titers to check or confirm serological response and determine if a booster vaccine should be given. I don't think this is routinely done in the UK for MS patients as far as I'm aware. Apologies for the size of the writing on this next slide. It is a great slide, so I did want to include it, but that's why I've tried to incorporate the little pop-ups to make it more digestible. It's a table of vaccines that's recommended for MS patients starting disease-modifying treatment. As I said at the beginning, the UK or the NHS must follow its agreed national guidance from the Green Book. And it's unlikely that GPs will be allowed to prescribe outside of the Green Book guidance. So whilst the ECTRIMS consensus and UK practice recommendations are broadly in alignment with each other, there is some variation, and I'll try to clarify that now. Flu and COVID are straightforward in that they're recommended for all MS patients. And similarly, MMR and diphtheria, tetanus, pertussis are also similar in that they are advised according to national guidance, which is usually part of the childhood vaccine schedule. It's for the pneumococcal vaccine. So the ECTRIMS group recommend this vaccine for all patients starting immune suppressive therapy. The Green Book, however, restricts pneumococcal vaccine to individuals judged as being high risk. It doesn't explicitly state who high-risk patients are, and also it usually recommends one dose only of pneumococcal vaccine. I think most UK centres are advising pneumococcal vaccine pre-anti-CD20, but some centres, for example, Cambridge, are also offering it before cladribine, alemtuzumab, and S1P inhibitors. Is the varicella vaccine. So it's recommended here via the ECTRIMS document for all VZV seronegative patients. In the UK, this vaccine is recommended only for healthcare workers and lab staff at risk of exposure or for close contacts of immune-compromised patients. Therefore, commonly our non-VZV MS patients have ended up buying their vaccine privately or from a high street pharmacy, unless they have a particularly sympathetic GP or practice nurse. Next one is HPV, recommended here for men and women intended to receive alemtuzumab, cladribine, S1P modulators, and anti-CD20 antibodies. The Green Book differs again significantly in restricting this to those aged 11 to 25 or are via sexual health clinics. Similarly, the HPV or the herpes zoster, the Shingrix vaccine, is recommended for those over 18 starting cladribine, alemtuzumab, S1P inhibitors, natalizumab, and anti-CD20, whereas the Green Book restricts its use in the NHS to adults aged 60 to 79 and those severely immune suppressed individuals aged 50 and over. And again, the definition of severely is not explicit. So this could cause confusion if MS centres start to advise their patients to go and get it, especially if GP practice managers disagree. And then the last vaccine is Hep B vaccine. It's recommended here for all high-risk patients, particularly if starting anti-CD20. And then in the UK, Hep B vaccine is usually targeted to children as part of childhood vaccine schedule or to those at high risk of exposure of infection due to lifestyle, occupation, or certain medical conditions. So lots of people won't have had the Hep B vaccine. So there is quite a difference between what the ECTRIMS guidance recommends in UK practice. The ECTRIMS document then goes on to discuss immunisation in special populations, particularly pregnant, elderly, or children, or those travelling. These again are areas where there's little or no published guidance. But the group have drawn experience from use in other populations. For children, national vaccine guidelines apply and are ideally completed before immune suppression therapy starts. And the same precautions with respect to disease-modifying treatments for adults apply to kids. Vaccination of women in pregnancy is fairly similar to those without MS, which according to the national guidance includes flu and pertussis. But again, planning in advance prior to conception and prior to starting disease-modifying treatment is recommended. Recommendation 7 in this section advises that for newborn babies, prior to administering live vaccines, B cell levels are checked if they have been exposed to anti-CD20 treatments in utero. And recommendation 8 advises to avoid yellow fever vaccine if breastfeeding. This question 6, addresses immunisation in the elderly. It highlights the higher risk of severe infection and altered immune response to vaccines. The same strategy applies as it does to the adult MS population in terms of which vaccine, timing, and precautions. If anything, elderly the elderly in the UK are more eligible for vaccines due to their increased risk of infection. And finally, last slide is regarding vaccination for the international traveller. The message about advanced planning is repeated. If possible or if needed, travel plans should be discussed with a travel specialist in combination or in conjunction with the neurologist. There is a suggestion about post-vaccination serology if needed, and possibly booster vaccines being administered, but also general travel advice and precautions can be provided. So that completes my summary of the ECTRIMS EAN consensus on vaccination in people with MS in comparison to UK practice. Quite a lot of information.
Fantastic, Eva. That's an awful lot of information that you've managed to summarise really well there, and it's really helpful to have the comparison to the Green Book, which we have to follow here in England. So that's really helpful and throws up a lot of really helpful discussion points as well. I'm sure we'll have lots of questions coming through, so do submit your questions on the question and answer function. And I think one of the key things that came through from the ECTRIMS guidance was the message that vaccines are safe for people with MS. Because I think there's still some neurologists that aren't quite sure if people with MS should have vaccines and whether they increase the risk of relapses or disability. But they did a very good review looking at the papers and showing that actually there is an increased risk of a relapse following a vaccine or an increased risk of disability to progression. So we can be really confident as healthcare professionals to say that, you know, vaccinations, the benefits far outweigh the risks. And anything you wanted to add, Myra, in terms of what you do locally in Ayrshire? Is that sort of the guidance that you're following currently,
Yeah.
or is that to come into practice still?
Yeah, I think one of the things that this highlight, you know, even our early discussions highlighted was that nationally, I think everyone does something quite different. And as you were saying there's still quite a lot of neurologists who think that we shouldn't be given vaccines, but also there's an awful lot of patients who were told that 20 years ago.
Yep.
So that makes it very difficult to have that conversation, you know, to change their minds of something that, you know, that they were told 20 years ago. So, you know, for me, it highlighted, you know, the need for maybe to try and look at some sort of national guidelines so that maybe that we are trying to work towards doing the same. Because, you know, for a patient, if a patient's moving from Scotland to England, to me, their care and what they get should be the same. And I think obviously, you know, that, you know, as you say, it varies from neurologist to neurologist and from area to area.
Yeah, absolutely. Yeah, and I think Eva highlighted a good point, which was what to do about the anti-CD20 patients. So those that are getting, say, ocrelizumab every 6 months, when do you advise them in terms of timing their vaccination? And I think that does vary around the country. And I think the data that's in the ECTRIMS guidance, there's some data that if you potentially vaccinate between 3 and 6 months, they may have a better response than 0 and 3 months, but it's fairly light. And actually what some of the papers showed is that even at 12 months after the last dose, the vaccination responses still aren't what you'd expect with healthy controls.
Yeah.
So it is tricky, especially like you say, if you've just had your Ocrevus in September and then the flu season's kicking off in October, do you really tell them to wait another 3 months, particularly when that flu rates go up around sort of Christmas and at that time they may not produce a B cell response, an antibody response, but what we don't know is whether they'll get a T cell response to the vaccine, which may offer some protection, if not the full protection.
Yeah, if you even think about around when all the you know the COVID started and how you know fearful patients were about getting vaccines and you know and I think obviously none of us really knew, everybody was just sort of stabbing in the dark, so it was difficult to kind of reassure patients around that time, wasn't it?
And we've got a question that's just come in, which is regarding chickenpox vaccine. So what do you do if a patient's been vaccinated with the chickenpox vaccine but doesn't develop immunity after completing the dose? So that's a great question. Certainly in Cambridge, we screen people for VZV, IgG before starting treatment, and if they're negative, then we advise the 2 doses of the chickenpox vaccine before starting immunosuppressive treatment. What we don't do actually is, as Eva said, I think it's not common to then recheck that the antibodies have formed and that the patient's responded. I think even if they hadn't responded to 2 doses of the vaccine, there probably isn't much point in going for a third, but you could offer that as an option. Obviously, that would then delay further the time to start treatment with MS. So you have to weigh up the delays to starting DMTs and the risk of disability that could pose against the need for immunity to chickenpox. But if that person did go onto an immunosuppressive DMT, we'd counsel them carefully. So we'd want people around them to be vaccinated. Obviously, if there was contacts close that have got chickenpox, they should keep away. And if they were exposed to the chickenpox virus, they would need to seek help quickly and get some of the IVIG prophylactically to avoid a severe infection. I don't know if, Mario, if you do anything differently if patients don't have immunity.
No, and actually that's the first case study. We didn't recheck after we gave the vaccine.
Yeah.
Similar to us, we were actually advised not to recheck. So
yeah, there's it's getting the balance, isn't it? You can spend a long time counselling on vaccinations, which is obviously really important. But if you've got somebody with a very active scan that's got lots of enhancing lesions, and you've got to get them on ocrelizumab or Lemtrada or natalizumab quickly, you have to have that discussion sometimes at the MDT about, okay, they're not immune to rubella. What do we do? Do we stop and wait and do the vaccinations, or do we carry on and get on treatment as soon as possible, because we can see that their scan's awful and that, you know, with every month that passes they're at risk of more disability. It's a tough call sometimes, and very topical at the moment, obviously, with the rise in measles cases in the UK. So lots of people missing out on measles vaccinations, and a rise in cases, which is going to cause problems, I think, for some of our patients. And then we've got another question just come through, which is about the Rotarix vaccine for babies exposed to Tysabri. Do we have any evidence about why live vaccination should be avoided for these babies? So I think obviously the guidance is clear in terms of what you do after an anti-CD20 therapy. So if the baby's exposed to anti-CD20 therapies through breast milk, for example, which obviously wouldn't be advised and would be against the SMPC, but if that was the case, then they should avoid live vaccines. But in terms of the Tysabri, yeah, I'm not sure about avoiding the Rotarix virus for patients whose babies have been exposed to Tysabri. It's not something that we generally advise in Cambridge, but I don't know if others do around the UK. No, great. So what I think we'll do is we've got some more questions coming through. So it's generating lots of interest, but I think we'll move on to the case studies, because Mario, you've got 3 really good case studies which highlight some of the common issues that we come across in the clinic. So I think if we go through those cases, that will cover some of the questions that are coming through, and then we can mop up any extra questions at the end.
Yeah, thanks, Claire. Yes, I think these are quite common sort of case studies, sort of patients that we do see in clinic. So this lady was diagnosed with MS in 2016. She was on Tysabri, then obviously became JCV positive, high risk of PML. So we sort of gave her the options, and she had decided to go ahead with cladribine. So obviously, as part of her screening, her VZV was seronegative. So we then contacted her GP, who was in agreement that he would administer it for her, but obviously she required 2 doses sort of between 4 and 8 weeks apart. And this was also around the sort of whole COVID time as well. So everybody was a bit kind of edgy about things. And she was also waiting on her first COVID vaccine. So unfortunately, there was a delay, and the neurologist at the time wanted the patient to have the 2 vaccines. You know, I know some centres, they would have 1 vaccine and start the treatment, but our neurologist had wanted her to have the 2. So there was a delay. And as Claire pointed out, a lot of these patients, you know, they're highly active disease, and a delay, obviously, that coming off Tysabri, rebound activity. So unfortunately, this patient did have a relapse during that period, and actually has become quite disabled due to same. So that's the sort of first case study.
Yes,
obviously, I think with these, you can learn from them, can't you? You can learn from, you know, what we know now to what we knew then.
Yeah, and like you say, it's a very difficult call, isn't it? Because chickenpox in adults is a really serious illness, and that patient would potentially end up hospitalised with a very severe infection. But equally, balancing that against the risk of very active MS, it's not an easy decision, and there's often no right answers. You'll never know sometimes whether you made the right call or not.
yeah. I think for the patient, obviously, she's quite upset that, you know, obviously she went all that time and then waiting for the, and, you know, and it's waiting for the GP, waiting for a GP appointment for her to have, you know, it's all these weeks went on, you know, and obviously she's quite annoyed about the whole situation.
Yeah.
And what do you think now? Would you go back and do it different, or?
Well, I think, you know, at the end of the day, if the, you know, the consultant wanted us to wait, you know, you can't really go against that.
Oh,
you
no,
know?
no, yeah, as a service, what do you think?
Probably, yeah, I would think now that there's maybe a bit more guidance. You know, back then we didn't really have the guidance. So, you know, I think now, you know, with the ECTRIMS information, I think, yeah, we probably would. I think you would, as Claire says, I think you have to weigh up, you know, the risk and, you know, against sort of disease activity.
And I think we're, like you say, we're a lot more aware now. I think most centres coming off natalizumab and switching to a different drug, you'd be very concerned about rebound activity, and probably would, in this situation, advise that the patient's not immune, but if they have contacts, to seek medical help quickly and get the IVIG.
Yeah.
All right, so we'll move on to case 2.
Okay. A 23-year-old female diagnosed in 2022 and adopted to go ahead with Kesimpta. We discussed obviously all the different screening bloods and the vaccines required as part of our screening programme. This patient unfortunately had a COVID vaccine, and she was adamant that her MS started following that COVID vaccine. So she was she was adamant that, you know, if she required any vaccines, that she wouldn't be having them, and no amount of sort of explanation or reassurance would change her mind. You know, and actually her relapse at diagnosis, I mean, she was in a wheelchair, you know, and really severely disabled. So, and it was only like a few days after she had the COVID vaccine. So she was, you know, she was absolutely adamant that that's what done it. So that it was really difficult. But, you know, with discussion with the rest of the team, we decided, I mean, thankfully our screening bloods were fine, but we agreed that, yeah, you know, we would go ahead with the treatment, but obviously we would just try and continue to counsel her, you know, throughout, you know, and hopefully as time went on, things would change. But, you know, on this, we just felt her disease was so active that we had to really start treatment as soon as possible. So we went ahead with that.
And I think that's a really common scenario. And it's in some ways easier when it's a young 23-year-old who hasn't got other risk factors for COVID. But as you know, you sort of treat sometimes the primary progressive patients who are much older with higher disability, then it's much more of a concern, isn't it, if they weren't engaged with COVID vaccination?
Yeah, absolutely.
Yeah.
Absolutely.
And you try and do, like you say, gentle persuasion and explore their fears. But actually, some patients have very strongly held beliefs about the COVID vaccine, and you can spend hours, but you can't, unfortunately, shake those. Yeah, we did have early in the pandemic in Cambridge one of our MS patients in their early 40s without other COVID risk factors that was on Ocrevus that died from COVID. And we do share that sort of story with our patients that are vaccine reluctant. And I think for some of them, they do take that on board. But for others, they're very entrenched in their views, and you can't sort of shake them.
Yeah, and I think just because obviously she took the symptoms so quickly after the vaccine,
yes,
that was, you know, and there's so, you know, and again, there's so many patients now, you know, as I say, 20 years ago, we used to tell them they couldn't get their flu jab, and they're still, you know, no, that's what I was told, and you know, they're sure that that's what triggered their MS, so, you know, and no amount of persuasion will change their minds.
And we have all seen cases of, you know, very rare but new onset demyelination following vaccination. So it is something that can happen, and you can understand the patient concerns in that scenario.
I think the good thing now, when maybe we do have a bit of evidence we can share with the patients as well, you know, about the safety of vaccines.
Yeah, fantastic. So we'll move on to case 3.
And this is one, again, this is quite a common one, I think, in most places. So a 37-year-old man diagnosed 2018, previously on Brabio, and then that had to be stopped, and we were escalating him due to disease activity. He decided to go ahead with ocrelizumab. Unfortunately, I think he had about 3 or 4 infusions, and his relationship broke down. And I think that's the thing, you know, you can plan, you can, when you're screening patients, you can talk about travel, but life changes and their lives change, so it's never ever, straightforward. So, his relationship broke down and he decided he wanted to travel. But to some of the places he was going, he would require the yellow fever vaccine, but obviously it was not to be given during the treatment. So, a few weeks of humming and hawing and, discussion with the rest of the team and the patient. And I mean, in the end, he did not have the vaccine. However, I think he was absolutely terrified about going anywhere that he was going to expose himself to yellow fever. And he kind of changed his travel plans. But for me, it kind of it kind of reinforced the fact that, yeah, we can do all the preparation and we can, give patients advice, when we're screening them, but things in life change and their lives change, and none of us know what's going to happen, around the corner. So for me, this was, as I say, he was, after we kind of had so much chat about the yellow fever, I think he was just so fearful of having it, and then also fearful of going anywhere where he might actually develop the yellow fever. So he decided he would change his travel plans.
Like you say, it's very hard to predict the future, isn't it? And it's we have a window of opportunity at the beginning of treatment to get people vaccinated, but we also have to balance that against getting on and starting them on treatment. But it is something that comes up very commonly in discussions in clinic. And the yellow fever vaccine obviously has had bad press in terms of MS. So there was a small case study of 7 patients who had what seemed to be very high relapse rates following yellow fever vaccine. So for a long time, I was very cautious about recommending yellow fever vaccine for MS patients. But in the last few years, there's the 2 studies that are quoted in the ECTRIMS guidance. So 2 bigger studies, still fairly small numbers, but one I think was about 23 patients and the other was about 100 patients. And both of those showed that there was no increased risk of MS relapse following the yellow fever vaccine. So in principle now, I don't have any concerns about recommending yellow fever vaccine if they're not on immunosuppression, or recommending it before starting DMTs. But in a scenario where they're already on treatment, you wouldn't want to sort of take them off and wait for them to immune reconstitute to vaccinate and then put them back on again if they've got active
That was the
MS.
kind of guidance really before, wasn't it? Wait, take them off and then wait till the B cells are recovered.
And that's one of the questions that's just come through. Actually, is there any evidence that yellow fever vaccine can worsen MS or increase relapse risk? So I think we can say now that study that was published, that case study of just 7 patients, has since been superseded by bigger studies showing that it is safe, but it was an initial concern from the previous study. Yeah. And there's other factors, isn't there, with travel? So a lot of our young patients want to travel, and there's other measures that they can take. Obviously, vaccination's a huge part of it, but making sure they've been to a travel clinic and had careful counselling about other aspects like malaria prophylaxis and about avoiding bites and eating the right foods and avoiding local water and all of those things that are, an important extra step. Yes, not just the MS patients, the entire population should. Yeah, absolutely. Fantastic. So just before we go to the 5-minute break, I'll just check if we've got any other questions and answers coming through. There's none at the moment. So it might be worth us just pausing to sort of share what we do locally in each of our centres, because I think, like you say, it's very common that different centres do different things, and it's not that one centre is better than the other or that one centre's doing it right and the other's doing it wrong. It's just that we all look at the guidelines and do our best to interpret them and do what we think is practical and sensible for our patients. So to run through what we do in Cambridge, we try and get people vaccinated early, even before they come to their first MS-DMT appointment. So when I receive a referral, I write to the patient and explain what will happen in clinic and ask them to have some blood tests before they come to clinic. And in those blood tests, we do all the screening bloods, which includes screening for the VZV, IgG to check they're immune to chickenpox. And we also screen for the measles, mumps and rubella IgG. And I know that we can just take an MMR vaccine history from them. But if we wait to do that when they're in clinic, what we've found is that often they're not really sure what vaccines they have and haven't had. and the sort of history of MMR vaccine is a bit murky. So it's quite difficult to know for sure if they've had two definite MMR vaccines in the past. So we find it easier just to check for the antibodies, and then we've got those fairly quickly even before they come to clinic. And if they need an MMR vaccine, I write to them and say, you're not immune to measles, I recommend you go and have your MMR vaccines. So often by the time they come to clinic, then they've already made a start on their vaccination schedule, which can be quite helpful. Yeah,
Claire, would you do that for all DMT patients?
yes. And going back to your point of you don't know what's going to happen in the future. So you might start a patient on glutathione acetate, though I guess we don't do that very much now, but you might start them on a lower efficacy treatment and then escalate later on. And what you don't really want at the time that you're trying to escalate treatment is to be delaying patients because you're waiting for them to be vaccinated. So any patient coming to clinic, we give the same vaccine advice and do the same screening, regardless of what they're going to start, so that they're covered.
Yeah,
I think one of the other challenges is keeping up with the Green Book and the various recommendations and how those change over the years. COVID recommendations changed overnight, and we didn't know until we checked the Green Book. And then, obviously, more recently, the Shingrix vaccine. Have you had any pushback from the GPs about who you've asked to get vaccinated? Because that's a consideration that a big service needs to take into consideration, before they start issuing advice.
Yeah, so that's a very recent changes in the last few months, and we've just updated our consent letters. So for the S1Ps, the anti-CD20s, cladribine and Lemtrada, we've got a section in the consent about vaccination and responses to vaccine. And we've got in there that if you're over 50, that we recommend having the Shingrix vaccine. So far, we've not had any pushback from GPs, but it's not that common that we see patients over 50 that we're starting treatment on. Most of the patients are 30s, 40s, but at least we can highlight it so that when they, if we've got some in there that are 48, they know that when they turn 50, they'll be able to get the vaccine.
Mm-hmm.
Yeah, and what do you do at the National EFA in terms of screening for vaccine cover? Is that something you go back to the GPs and ask about, or ask the patients direct?
So we will ask at the point of them starting a new disease-modifying treatment in that clinic appointment, but we will only do we'll verbally ask them, are you up to date with your childhood vaccine schedule? If there's any doubt or suspicion, then we might check their antibodies for MMR. And we've done that for a few, and then actually one very recently has had their MMR just before they've started their immune suppressive therapy. But we don't sort of wait for delay treatment to get the like a fax copy or an email of their proof of vaccine, simply because that can just take a long time and then cause an unnecessary delay of starting treatment. So usually a verbal is sufficient. Obviously, if we had doubts about the patient's cognitive ability, we would double check.
Yeah. And it's the chickenpox vaccine that's a tricky one, isn't it? Because although we all know they should be vaccinated against chickenpox if they haven't been exposed as a child, actually the Green Book doesn't allow for GPs to give the chickenpox vaccine in that scenario. And we haven't been successful in cajoling GPs into giving chickenpox vaccines, so the patients have to go and pay for that privately. And it's not a small amount of money. It's around £100 for one vaccine, and then you have another one, so that's £200, which for some patients is quite a lot to be spending.
Mm-hmm.
And then just looking at the questions, so we've got a question come through about the BCG vaccine in infants born to mums who received Tysabri in pregnancy, and similarly, any advice about the BCG vaccine for anti-CD20 therapies postpartum. So I think the anti-CD20 guidance is clearer, isn't it? That you're supposed to avoid live vaccines if the baby's potentially been exposed to anti-CD20 therapies. Obviously, the ABN pregnancy and breastfeeding guidelines are very different to the SNPC guidance, and the ABN pregnancy guidance and breastfeeding guidance suggests that you have a discussion with the mother about the risks and benefits of live vaccines after anti-CD20 therapies, and if you're breastfeeding, the amount that actually passes through the breast milk to the infant is likely to be low. So the risk of a live vaccine like the rotavirus vaccine or BCG is likely to be very low. But you have to have that sort of risk-benefit discussion. And likewise, I think for Tysabri, we don't routinely recommend, but I think we've actually come across that scenario in Cambridge where a patient's come to us and said the infant's been recommended to have a BCG vaccine for mothers who had Tysabri in pregnancy. I don't know if anyone else has come across that scenario.
Claire, in terms of obviously you're doing the screening for vaccines prior to them starting any DMT. Would you ever repeat, like say for ocrelizumab patients sort of before any sort of infusion, do you ever repeat them?
Do you mean when they're already on treatment to see if they've disappeared? No, so we don't. We tend to get them vaccinated. We don't check that they've responded to the vaccines, and when they're on treatment, we don't check that the antibodies disappear. I think the OPERA-1 and the OPERA-2 trials did look at whether patients maintain their vaccine responses from previous vaccines, and they did on the data that was presented in OPERA-1 and OPERA-2. So you can expect that they will retain their immunity to the childhood vaccines that they've already received. But obviously the ECTRIMS guidance does recommend that you do the antibody tests after the vaccinations. But it's often just quite impractical. We have patients that travel 2 hours, an hour and a half to get to the hospital. So to bring people back and forth for blood tests, and the GPs might not be willing to do them. So thank you so much, Mari and Nifa, for joining us this evening and for those excellent case studies and that excellent run through of the ECTRIMS guidance. It's a really important area for everyone working in the field of MS, and it's great to have had an update. For people that want to go away and do more reading, I stumbled across the National Measles Guidelines today. So they've just been published this month. And obviously with the measles outbreaks in the UK at the moment, that's worth having a look at. But in summary, if you've got detectable measles, IgG, you don't need IVIG. So do a rapid test. And then if you've got antibodies, don't worry. But if you haven't, then you need to direct the patient for some IVIG. Great. Okay. Well, thanks very much.